Alright, so far we have worked through a ton of lessons in this 12-lead EKG series, and I know this lesson is the big one that most have been waiting for. In this lesson, we're finally going to be talking about the big one, ST elevation, and particularly STEMI on our 12-lead EKG. We have a lot to cover, so let's get started. Alright, I welcome you guys back to another video lesson from ICU Advantage. For those of you who don't know me, my name is Eddie Watson, and my goal with this channel here is to try to give you guys the confidence to succeed in the ICU by taking these complex critical care subjects and making them easy to understand. I truly hope that I'm able to do just that. If I am, I do invite you to subscribe to the channel below. Make sure you hit that bell icon though, that way you never miss out when I release a new lesson. Now also, if you do enjoy these lessons and you'd be interested in getting CE credits for following along with them, then head on over to icuadvantage.com/academy and join the ICU Advantage Academy, where you can watch all these videos. You'll have access to all the notes, including the new notes that I'm currently working on updating, as well as audio-only versions of these lessons. And most importantly, you'll be able to actually earn CE credits for participating in this education. So I've got some great deals going on over there, so make sure and check that out. Now, if you would like to support the channel but really don't have a need for the CEs, or if you just want access to things like the notes, then you might also want to take a look at either the YouTube or Patreon memberships. Again, links to both of those. All that stuff is going to be down in the description below. Of all the things that we can determine from our patient's 12-lead EKG, the identification and subsequent management of patients having an ST elevation myocardial infarction, or STEMI, is probably the most important. This is a life-threatening situation, and without prompt and accurate identification and interventions, the patients will suffer life-changing damage or even death. Even with rapidly identifying and treating these patients, we still may not actually be able to ultimately save them. But being able to recognize this early and start a cascade of treatment and interventions can absolutely save someone's life or reduce the amount of damage that's done to their cardiac muscle. Thus, this lesson is probably going to be arguably one of the most important ones of this series. As I said, we have a lot of information to cover in this lesson, so let's dive into it now. So let's start off talking about the pathophysiology of STEMI and what exactly is happening when a patient is having a STEMI. So if you remember from the last lesson, which I'll link to up above here, we talked about what was happening with blood flow in patients with ST depression having an NSTEMI. Well, typically we have a similar ACS process that's happening here with STEMI. Again, we have our coronary arteries that are supplying blood flow to all the cardiac muscle cells. Again, we have a plaque that is developed and then subsequently ruptured, causing again that formation of the thrombus. The difference now with STEMI is that this thrombus-plaque combo is now completely obstructing the flow of blood. Any area of the heart that is downstream or distal to this obstruction is now no longer receiving any blood flow and thus no oxygen. Now, we can have other causes that are not ACS-related causes, though ACS is certainly the vast majority of these etiologies. Some other possible causes could be coronary embolism, coronary dissection, or coronary vasospasm. Again, these conditions, if they occlude or cause a situation in which blood flow is no longer continuing to flow to the coronary artery, then myocardial infarction would be taking place. Again, these are a small number of cases when compared to the classic ACS that I just described above. So when this happens with our patients, the area of myocardial tissue that's perfused distally to the obstruction is now without oxygen and becomes damaged and quickly will begin to die. So this leads to large areas of injury and thus the ST elevation that we see on our EKG, and then eventually the necrosis and cell death will create that electrically inactive tissue that we talked about in that AMI intro lesson. Again, I'll link to that up above, giving us the quote-unquote window through the heart and producing those pathologic Q waves. Now, this injury and infarction is what we call transmural, or going the full length of the cardiac tissue. This large area of myocardial tissue does not depolarize properly, leaving this tissue electrically positive, giving us that classic ST elevation that we see on EKG. If we see this ST elevation greater than 1 millimeter, so one small box, in any leads except for V2 and V3, and in 2 or more contiguous leads, then this is our criteria for STEMI. Commonly, we can see some physiologically normal ST elevation in V2 and V3, therefore criteria in these leads is a little bit more involved. Basically, if our patient is a male patient greater than 40 years old, then we're looking for greater than 2 millimeters or 2 small boxes. If it's a male less than 40 years old, we need greater than 2.5 millimeters or 2.5 small boxes. And for women of any age, we're looking to see greater than 1.5 millimeters or 1.5 small boxes. And all of this is happening fairly quickly. The longer the time without blood flow and oxygen, the more damage that takes place, and ultimately the more of the heart that dies. The more of this that takes place, the more long-term complications that will result, including decreased function of the heart, heart failure, and if large enough, can lead to death. Therefore, just as with strokes, time is important. Time is muscle. The more time it takes to reestablish perfusion, the more muscle dies. And while it's beyond the scope of this particular lesson and certainly warrants its own future lesson, typically reperfusion will take place in the cath lab, although if one is not readily available or nearby, we can also give a thrombolytic, such as TPA or TNK, to break up that clot and try to reestablish perfusion as well. Now that we have that out of the way, now let's talk about the impact from all of this that we see on our 12-lead EKG. To start the discussion off, we need to revisit a topic we covered in one of the very early lessons in which we talked about contiguous leads. The significance of contiguous leads is that if we think about the position of our various leads and anatomically where they're looking at the heart, certain leads, typically nearby on EKG, are often looking at similar parts of the heart. Therefore, in situations like STEMI, where a large portion of the heart is being impacted, we will see changes on multiple leads looking in similar areas of the heart. This is significant because knowing this and knowing where certain leads are looking, we can determine what part of the heart is impacted and thus have a pretty good idea of the vessel or vessels potentially involved. What this means is we can pretty accurately determine the infarcted regions from the presentation on the 12-lead EKG. So let's bring up an example of a basic 12-lead again. If we look at our leads here and group them together again, we'll show the different contiguous leads that we have. We're going to start off with leads 2, 3, and AVF, and these leads are looking at the inferior portion of the left ventricle. Now leads 1 and AVL are what we consider the high lateral wall. V1 and V2 are our septal leads, looking at the septum, as well as giving us some anterior view. V3 and V4 are what we call our anterior leads, looking at the anterior of the left ventricle. And then finally, V5 and V6 are our lateral leads, looking at the lateral side and the apex of the left ventricle. Now, there's really not many things that I tell you guys that you really need to memorize on this channel, but this chart and these contiguous leads really is something you should commit to memory. It's really not that difficult once you know the pattern, so I really strongly urge you to do so. And one thing to note with our typical 12-lead configuration is that we're not going to have a direct view of either the posterior wall of the left ventricle or the right ventricle. So I will discuss this briefly later in this lesson, but to view each of these, we would need to place some of the leads in different locations. Now, knowing the region of the heart that's being impacted on EKG, we can then combine this with our knowledge of coronary blood flow, again linked to that lesson up above, to have a pretty good idea of the blood vessel or vessels that perfuse that area of the heart. So for instance, if we look at our inferior leads 2, 3, and AVF, most people, so about 90%, are actually perfused by the right coronary artery, while 10% are perfused by the left circumflex. Now for leads 1 and AVL are high lateral leads, that these are perfused by the left circumflex. Septal leads V1 and V2 are actually perfused by the left anterior descending, or LAD. The anterior leads V3 and V4 are also perfused by the LAD. And then finally, the lateral leads V5 and V6, they can be fed by the distal LAD, the left circumflex, or the right coronary artery. Now, to complicate things more, we don't always just see one area or region that's impacted. We can have multiple areas such as anteroseptal, anterior lateral, or even inferior RV, just to give you a few examples. I will briefly hit on this lesson, but just keep this in mind that when evaluating EKGs, it's not always clean cut with just one region impacted. All right, and then the last thing I want to cover real quick before we look at our STEMI EKGs is the concept of reciprocal changes. Again, I did briefly mention this in the AMI intro lesson, but I just want to hit on this again here. Due to the size and magnitude of injury that's taking place with STEMI, along with all that abnormal depolarization, that not only will we see the ST elevation in the leads directly viewing them, but the leads that are opposite or looking from the other direction will actually pick up this large electrical activity moving away, thus giving us ST depression. So this is what we refer to as reciprocal changes, and these are commonly seen in patients having STEMI. Okay, now that we have all that information covered and out of the way, let's start to look at some EKGs of STEMIs in different regions of the heart. And to help with the identification, I am going to keep this chart up top, kind of showing our infarcted regions. All right, so let's start off looking at our inferior wall. So remember, this is seen with leads 2, 3, and AVF, and is typically perfused in 90% of people by the RCA, and the other 10% is the circumflex. Our reciprocal changes typically present with ST depression in the high lateral leads 1 and AVL. So if we take a look at our EKG here, you can see clear ST elevation in leads 2, 3, and AVF, along with those reciprocal changes of ST depression in 1 and AVL. This is our classic inferior wall MI. Now, on the subject of inferior MI, knowing that most people have this region perfused by the RCA, we also would be concerned that the patient would have some RV involvement and could have an RV infarct as well. If the patient is having an RV infarction and the RV is weakened, remember that the right ventricle is very preload dependent. The right atrium helps to push the blood flow forward to fill the right ventricle. This process is still primarily driven by venous return. Giving a vasodilator such as nitroglycerin or even morphine could significantly impact this preload and could have significant effects on your patient's hemodynamics and blood pressure. So I've actually seen patients with very good blood pressures that actually quickly plummet after being given sublingual nitro, so it's definitely something to be aware of and to evaluate when you have an inferior MI. So if you do identify an inferior STEMI, before you consider giving nitro for chest pain, you really should get a right-sided 12-lead EKG. To do this, it's pretty simple. We actually keep our limb leads where they are, and what we do with our precordial V leads is we do a mirror image on the patient's chest. What this means is that V1 is now going to be the patient's left sternal border, fourth intercostal space. V2 is now going to be on the right sternal border, fourth intercostal space. V4, we are going to have on the patient's right side, midclavicular line, so that nipple line, fifth intercostal space. V6 is again along that mid-axillary line, fifth intercostal space, on the same horizontal plane as V4. And then V3, we want to put kind of diagonally in between V2 and V4. And then V5 is going to be in the middle of V4 and V6, again along that horizontal plane. So this is going to give us a view of the right ventricle and really help us identify any RV involvement and determine whether the patient should be considered for sublingual nitro or whether we also want to be concerned with like morphine administration as well. All right, so now let's take a look at an anterior wall MI. So remember that these are leads V3 and V4, and this region is going to be perfused by the LAD. So reciprocal changes are not going to be seen as they would actually show up posteriorly, which, like I mentioned, we don't have a view of with our traditional 12-lead setup. Now, a true isolated anterior wall MI is actually pretty rare. And so this is actually going to segue into a concept that I mentioned earlier, talking about multiple regions being impacted. Oftentimes when we see an anterior wall MI, it's going to be combined with a septal wall MI, something we call anteroseptal involving V1 through V4, as well as extending into the lateral wall, so an anteroseptal with lateral extension, which we'd also see in V5 and V6, as well as potentially in 1 and AVL. So here's an example of such an EKG. In this example, we have a lot going on here. You should pretty easily be able to see the ST elevation meeting all criteria in leads V2, V3, V4, and V5. But if you look at V1, you can also see ST elevation there, and V6 is a little harder to see, but especially if we look at the last one here, we can see the ST elevation as well. So seeing all these areas of ST elevation, we have it in our septal region, our anterior region, as well as that lateral apex region. In this example, we don't see any ST elevation in our high lateral leads, so 1 and AVL, but we do see the reciprocal changes in 2, 3, and AVF. So given the rarity of an isolated anterior MI, here's actually an example of the closest I could find to that. In this example, we definitely have ST elevation in the anterior leads V3 and V4, but hopefully you also see the ST elevation in V2 and V5. So V2 being septal and V5 being lateral. So this really isn't a true isolated anterior MI. All right, now let's talk about the lateral wall. So here we would see our ST elevation in 1 and AVL being our high lateral, as well as V5 and V6 being our lateral or apical. So the left circumflex feeds the high lateral, and for the lateral apical region, this can be any of the three, so LAD, circumflex, or RCA. Reciprocal changes from the high lateral region are seen in the inferior leads, so 2, 3, and AVF. A lateral wall MI can occur by itself, but it's also commonly seen in combination with other regions such as anterolateral, anteroseptal, with lateral extension, as well as inferolateral, just to name a few. So in this example here, we can see clear ST elevation in leads 1 and AVL, but also V5 as well as probable elevation in V6. We do have our classic reciprocal changes in the inferior leads, 2, 3, and AVF, but we also see some ST depression in the anteroseptal leads, V1 through V3. These could be reciprocal changes, so maybe think posterior MI in left-dominated patients, or ischemia in those regions as well. All right, and so speaking of posterior MI, as I mentioned, this region is actually one that we don't have a direct view of with our typical 12-lead EKG. That said, we do have a good view of where our reciprocal changes would be. So given a posterior MI, we would expect to see reciprocal changes in the anterior and septal leads, so V1 through V4, typically seeing this greatest in either V2 or V3. If you see this on an EKG, you should be suspicious of a posterior MI and get a posterior view 12-lead EKG. So again, this is also pretty simple to do. And to do this, basically you're just going to take leads V4, V5, and V6 and move them posteriorly, giving us what we call V7, V8, and V9. To place these, V8 is going to be mid-scapular line, the fifth intercostal space, with us then placing V7 on the patient's left along the axillary line, same fifth intercostal space and same horizontal plane as V8, and then V9 is going to be placed to the right of V8 along the spinal border. Again, fifth intercostal space, same horizontal plane as the other two. So this is going to give us a view of the posterior of the heart with those leads V7 through V9, and thus we'd be able to actually see ST elevation in these leads if a posterior MI was present. Now also of note, posterior wall MIs are commonly seen combined with inferior as well as RV infarcts. So as an example of just this, here's an EKG with high suspicion for a posterior wall MI. You'll note the deep ST depression in V2, as well as depression in V1. It looks like some in V3 as well. Along with that, we also see ST elevation in leads 2, 3, and AVF, with some reciprocal depression in AVL, indicating inferior wall MI, as well as some lateral involvement with elevation in V6, and looks like some in V5 as well. But given the anterior ST depression, especially the magnitude of it in V2, we would definitely want to get a posterior view to check for posterior wall involvement. All right, and then finally, the last thing I want to cover quickly here is left bundle branch block. So left bundle branch block holds a special place when it comes to MI. So first, it can complicate the recognition of STEMI, as a left bundle branch block can produce ST elevation and T wave changes that are pathologically normal for these patients. That can either give the false impression of a STEMI or actually mask a STEMI that's taking place. That said, patients with left bundle branch block can still have MIs, which is something I'll actually be diving into further in the next lesson. But in addition to that, a new left bundle branch block, especially in the presence of signs and symptoms of ACS and chest pain, that we consider this a sign of STEMI. So a study actually looked at this and took patients with new left bundle branch block and chest pain to cath lab and often found a complete occlusion. Sometimes, though, we don't always have a previous EKG to compare to, so when in doubt, if the patient presents like an MI with a left bundle branch block, we should consider it as such. We can also use something called Scarboza's criteria, which I am going to be discussing in the next and final lesson of this series to evaluate for acute STEMI in the presence of left bundle branch block. Alright, well, we covered a lot of information in this lesson, and this was a lot of really important information, as being able to identify acute myocardial infarction on EKG is probably one of the most important things to be able to do. Hopefully I was able to present this well and that you have a better understanding of what to look for when you're evaluating your patient's 12-lead EKG. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.